Good morning, everybody. So let's talk about chapter 11. So adaptations to aerobic and anaerobic training. Yes, resistance training is technically or could be anaerobic in nature, but it's a little different when we're talking about it in that sense. When we talked about it in chapter 10, that's more along the lines of resistance training for muscular adaptations. This is going to be a chapter that more or less concentrates on the type of anaerobic training that would be classified as, I guess, cardio-based, if that makes sense. Because we're going to be talking more about how the body will adapt due to training, which is more aerobic and anaerobic, in terms of the cardiovascular function, respiratory function, metabolic function, stuff like that. Okay, so let's get into it. What are we going to talk about? So some of the aerobic adaptations that we can see with training, we're going to talk about the cardiovascular adaptations, respiratory. There are some muscular adaptations that do occur. I mean, that's going to be kind of an obvious thing because you have to utilize muscles in an effort to run, walk, do whatever you're doing. So there will be some muscular adaptations as well. We see metabolic adaptations. We're going to look at the individual responses that occur from training, and then we're going to kind of touch on some of the anaerobic adaptations that can occur as well. So a little bit of terminology. What is aerobic training? Aerobic training is going to be more heavily focused on the cardiorespiratory system. It will improve the heart function, meaning that we will lower our heart rate at a given intensity. Even when we start to see some of the adaptations that occur with aerobic training, what's one of the indicators of an endurance-based or an aerobically based athlete? They have a lower resting heart rate. Well, guess what? That's an intensity technically at rest, okay, and their heart rate is lower. And then if you refer back to chapter 8, chapter 8, it should have been the cardiorespiratory chapter. Remember when we were looking at all the graphs about the differences between the cardiovascular and respiratory function of trained versus untrained, okay? Improved blood flow to the muscle. We're going to talk about a little bit of how that occurs. Improved respiratory function as well. Enhanced oxygen utilization at max. So our VO2 max is going to be increased with training. And it's also increased at submaximal efforts. All right. Aerobic training is also one of those things that's cardiorespiratory endurance. Aerobic training is going to be more primarily based around the cardiorespiratory system. Cardiovascular and respiratory system to maintain that oxygen delivery for that type of work. And the ability to sustain prolonged dynamic whole body exercise using large muscle groups. This is different than muscular endurance, although they kind of go hand in hand somewhat, okay? So when we look at anaerobic training, so real quickly, I'm going to go back a slide. Aerobic training, aerobic with oxygen. So this is going to be training that is more long-term in sense of duration. Let's take it as this, you're running a marathon, that's aerobic, okay? Oxygen is going to be more prevalent. Anaerobic, on the other hand, is going to be where we are not exactly without oxygen. I mean, I think I've made this point before. It's not like you're not breathing. It's that your oxygen intake is not meeting the demands that we are requiring, okay? That's more short-term, high-intensity type of work. We're going to look more at that ATP PCR, that glycolytic metabolism aspect. So both aerobic and anaerobic have some metabolic adaptations that occur. Aerobic going to be more along the lines in that oxidative system, apparently, and then anaerobic is going to be more that ATP PCR, that glycolytic glycolysis type of metabolism adaptations. we can see some muscular strength and endurance that occurs during this. This is why I say that some resistance training or resistance training kind of falls into that anaerobic training as well. We also want to look at it in the sense of when we talked in this is chapter 11, so chapter 10, about the adaptations to resistance training, we were more concentrated on the muscle. Okay, how are we going to build muscular power? How are we going to build muscular strength, hypertrophy? So we're more in depth in that chapter on how are we changing the muscle. Now this, when I say that anaerobic training can encompass resistance training, we're going to talk about muscular strength a little bit too. That's what we're doing. We're changing some of the adaptations to the muscle in other ways. Now we're going to understand how this type of training will change blood flow aspects or the metabolic aspects to that musculature, and the ability to maintain a proper acid-base balance. And just real quickly, muscular endurance, sustained repetitive contractions at higher intensities. So it's more related to strength and power, not aerobically, where we're going for hours on end potentially. Okay. So if we move on, so some of that cardiorespiratory endurance, we're looking at it, it's that maximal aerobic capacity and power. So that's our VO2 max. So that is, the VO2 max is when we reach that cardiac output max and that maximal difference in AVO2. All right. So it'll plateau or decrease actually with increasing intensity. Why do you think it no longer continues just to go up? And I don't know if I mentioned it to you this class prior. I may not have. I don't remember exactly what I've talked about in some of the videos with some of my explanations or examples, and then I don't know if it was my strength conditioning course. But here's what's happening. If you ever give or have someone perform a VO2 max test, some people will go and do as you're told, essentially. I mean, if you're not looking at the computer screen, you don't know how to read it, then you don't know what's happening, right? And so you're going to go until you can go no longer, like I told you. But if you go in and you start to see some of these higher level athletes potentially, if you were just to say, go until you can go no longer, they may reach their VO2 and they think, oh, well, I should keep going. I need to keep going. I need to keep going. It's not going to improve anymore, or it's not going to go up. Why? AVO2 difference talks about or cardiac output, excuse me, that's your heart rate and your stroke volume. What happens with stroke volume with exercise? It goes up to a certain extent and then it levels off or kind of dips back down, right? Doesn't matter if you're trained or untrained. That's what it does. It'll go up to a certain extent and then it starts to plateau, if not decrease a little bit, dip. Same thing with heart rate. Now it'll continue to go up until you, with intensity, but what happens at a certain point? If you're going 100% all out, your heart rate's not changing anymore. Well, guess what? That means that cardiac output now is level-headed. It's staying where it's at, if not dipping down a little bit, right? So same thing is going to happen to VO2 max. It's going to hit to a certain point, and then after a certain point, it's going to be leveled off. It's not going to be able to go up anymore in terms of single bout exercise. It's not to say that we cannot improve our VO2 max, but in a single effort exercise, it gets to a certain point and then it'll stop. The training that we do aerobically will start to increase that oxygen delivery and utilization. So in other words, you're becoming more efficient with your VO2 max, and it will start to increase a little bit. Because when we start to increase that oxygen delivery and utilization, what part of this equation do you think it's altering there? That AVO2 difference, right? We're going to deliver more oxygen to that working muscle, okay? This is when we start to increase our VO2 max, that means that we're going to be able to perform at a greater intensity. So let's just take this little graph down here. Okay. Yes, we can improve our VO2 max with training. I will tell you this right now. This while the graph is technically true, yes, we will improve VO2 max. This is showing a VO2 max change of, let's just call that an even 45 pre-training to near 60 post-training. That's near 15, a 15 VO2 change. That's tough, okay? And I'll explain to you why that's tough as we progress through this video and through this portion of the chapter. But let's just take this graph for a second, right? Let's consider blue to be person A and red to be person B, okay? And if I told you that you need to work at 60% of your VO2 max, okay? Person blue or person A, let's just say that they're 60%. Let's see how many dots are there. 1, 2, 3, 4, 5, 6, 7, 8. 8. So that means that we're going to have to go probably right around in here for 60%, maybe right there. So look at what that does. If that's the case, oh, excuse me, I don't have a pen on here, but there's my mouse. Hopefully you see it. That means that they're working at a speed, let's call it an 11, okay? 11 kilometers per hour, all right? Now let's look at person B, or the red. If that's the same kind of concept and their 60% is here, that means that they're working at 13 kilometers per hour. Well, guess what? If that's the case, then they're working at a higher intensity, which means in a sense, okay, because they're able to run faster at that given intensity. Well, what happens if we work and I was able to control everything and I put these two individuals on there and I made sure from start to finish, both of them are at 60% and neither of them are going to get tired. Let's just hypothetical, right? Who wins the race? Well, person B, the red. Why? Because their higher VO2 max means that they're able to work at the same percentage, but but performing it at a faster pace. Well, the faster person's going to win, right? Okay, so we have that, and there is the improved endurance potential, and I think that's what I just talked about. And then we're going to learn a few other aspects throughout the chapter that'll all tie that together. At submax endurance, so it's a percentage of your VO2. So this technically 100%. VO2 max is 100%. So if we look at submax endurance, that is technically anything under 100%. Okay, it is more along the lines of an indicator of lower steady state heart rate at a given intensity, meaning that what you're doing feels like less work, even though you may be working at a faster pace than somebody else. Okay, it's a better predictor of performance. A percentage your submax endurance versus and your lactate threshold are more of a better endurance indicator or performance indicator. I'm sorry. Your VO2 max is more along the lines of an endurance indicator. Because let's face it, a percentage of your VO2 max is going to mimic competition better. Because when we're talking about individuals when we're looking at percentage of VO2s, you're looking at individuals that are going to be exercising for quite a long time, such as marathons or triathlon, all that type of stuff. We're not looking at sprinters. A sprinter is 100% of their VO2 max, essentially, or 100% intensity. Okay, so when we look at individuals that are cardiorespiratory endurance based, that percentage of their VO2 max is going to be more indicative of competition, and increases overall with training. Again, go back, I'm going to go back a slide real quick. Go back to this aspect right here, this graph, okay, and the example I just gave you. If I'm looking at 60%, it's different pre-training versus post-training. Why? Because my VO2 is higher. And that means that inherently my percentages are going to increase. So what are some of those cardiovascular adaptations that are allowing for this? I just told you, the oxygen transport system, that fixed equation, that VO2 is your cardiac output times your AVO2 difference. Well, guess what? If we start to see changes in our stroke volume and our heart rate, that increases and changes our cardiac output at a given intensity. And then if we're improving our oxygen transport and delivery, that's that increase in that AVO2 difference, right? Let's just think about it in terms of this. Going back to the chapters that we've already covered, there's a couple of pictures, one that says AVO2 difference at rest and one that says it at exercise. Let's consider this. Replace rest with pre-training and exercise on the other one with post-training. We are essentially able to offload more oxygen during that period. That's going to allow for that greater AVO2 difference, okay? If we are able to do that, we increase our VO2 max. We will also see some changes in heart size. Enlargement indicates disease or athletic adaptation, meaning this. If you are in athletics, whether it be strength training, endurance training, anything like that, we will see a little bit of enlargement of the heart. Why? It's a muscle. We're working it out, right? So you're going to see a little bit of an increase in size, especially in that left ventricular wall. Okay, that's our biggest point of contention when we're talking about whether it's a athletic or exercise-based adaptation or potentially disease. Now, when we have cardiovascular health issues or chronic heart failure or congestive heart failure or anything like that, that's more along the lines of we have an even more of an increase in that thickening of the left ventricular wall, and it's due to a disease state, and that's a problem, okay? And we'll find out a little bit more about that moving forward. Our heart mass, left ventricular wall thickness, and left ventricular volume increases. Resistance training will increase the force of contraction, meaning that there's going to be a little bit more thickness to it. And then aerobic training will increase the left ventricular volume. So we're going to increase plasma volume. That's going to increase our end diastolic volume, which inherently is going to increase our stroke volume. Both adaptations can occur with any athlete. Okay, so it's not that you won't see one happen if they're not participating in everything. Typically, any athlete can have this type of change in heart size. So let's look at this real quick. Even when we're looking at it based off of runners, cyclists, and strength athletes. So if we're looking at our internal diameter of our left ventricle, right over here, the left-hand side, look at the differences between runners, cyclists, and strength athletes. Okay, now this is all in comparison to somebody that is completely untrained. All right, let's just take it from these athletes in particular. When we're looking at the internal diameter, the runner and the cyclist are going to have way bigger. Okay, this is starting to talk about that, how we can increase the volume of the left ventricle. Okay, of course they are. We just talked about that. We are going to increase the thickness of with strength training, but we're not going to increase the volume with it. If we look at the mean wall thickness, so average wall thickness, once again, now we start to see where that strength athlete is starting to show an increase that's similar to everybody. And that runner also has an increase. So it's not just the strength athlete. And then if we look at their left ventricular mass, obviously that's starting to take into account everything. Look at the differences. All athletes are well above that of an untrained individual. Obviously, your endurance-based athletes are going to have a little bit more of a change. Again, that starts coming in down here because they see more change in their internal diameter, which allows for a larger volume than that of a strength athlete. But what else are you seeing that might pique your interest with this graph? And typically, this is a little bit better when we're in person. But why do you think that the cyclists are showing more left ventricular mass, more of a wall thickness, and even that internal diameter? So why do you think that it seems like a cyclist is getting more out of it than a runner or strength athlete? I'll let you internally think for a second. Here's the deal. When we're thinking about a cyclist, I think a lot of people think that you're just going straight line sprinting type cyclists or super long distance, flat roads. No. If you look at cycling competitions, it's a mixture of flat, long duration and endurance type pedals, more downhill that is sprinting based. And then they have uphill, up mountain climb, whatever it is. That's a lot of strength. So cyclists inherently get benefits of both ends, being technically a strength athlete and an endurance athlete. So the combination training essentially shows us a greater increase in their overall left ventricular mass and why they're getting benefits of both ends. Continuing on, we're looking at our stroke volume. That increase due to the left ventricular volume increases, right? Again, if we're able to increase the amount of volume in the left ventricle, that means that there's more blood in the left ventricle, which means that when we contract, we have a higher stroke volume. Done, right? Plasma return increases, so that end diastolic volume or that preload during diastole increases our force of contraction. So once again, we're stretching that left ventricle a little bit, and then when it contracts, it's increasing everything. That increase, our stroke volume is going to be increased at max, submax, and at rest. I mean, we learned about this in the previous chapters, that this makes sense, again, if the heart rate goes down. Because if we're looking at it, cardiac output is the amount of blood, the volume of blood pumped per minute. Stroke volume is per beat. So if we want to maintain, oxygen delivery, right? Okay, even at submax or at rest, and I just told you that heart rate decreases with endurance-based athletes. What do you think the body's going to do in return to maintain some balance? Stroke volume increases, because now with each beat, I pump more. So when we look at it, if we're looking at how it changes over time, or if you just want to look at it here, untrained versus trained and highly trained. Now, that highly trained, that 90 to 110, at rest, that's pretty high. That might be, on the tail end of a spectrum of highly trained, what I like to call freaks of nature, right? A genetic freak. But mostly what we've seen is that the high-level endurance athletes, we've been able to measure their stroke volume up into the 70s, all right, where everyone else is in the 40s to 50s. Okay. So, or at least that's where their increase can go up to. 60s to our trained individuals can get up into the 70s and a little over that. But look at it like this. Look at your stroke volume. So once again, pre-training versus post-training. Look at what's happening. It's going up. Now, At the same time, I believe the next thing that we're going to learn about is the heart rate, or if there's not heart rate, I can explain it real quick right now. So if we see that we could even plot our cardiac output, if our cardiac output's going to keep increasing and our stroke volume is going up, odds are our heart rate is down. They go hand in hand. All right. If our cardiac output is remaining the same. So if we look at it like this, and I want to explain this a little bit. So if we look at our end diastolic volume, so that's the amount of preload that we're getting. Look what happens. Pre-training versus post-training. Post-training, that end diastolic volume is increased. So that preload, that stretching is increased. So it means we're getting more in there. In systolic volume, so once we've contracted, pre-training versus post-training, once again, that means that we are ejecting more, meaning that there's less in there following the contraction. All right, that's a good thing. If we look at our ejection fraction, it increases, meaning that we have less blood, once again, okay, less blood in the chamber following contraction. May have not explained this. I may have. I can't remember exactly what all we've covered. I don't think I got to cover any of the heart in person with y'all. But let's think about the heart as a cup. Okay, you've got liquid in the cup, and what happens if you just go? And this is it may help. You take your cup and you just quickly chunk it out, right? Chunk and bring it back. When you look at the bottom of the cup, is every bit of liquid out of there. And I'm not talking to go and dump the cup and shake it. I'm saying take it and right back. There's some left over, right? That's essentially kind of what the heart does. There's always a little bit left over in the end, and that's okay. We're built to do that. The problem being is that if we see that increase of that ejection fraction, meaning that if there's more and more blood being left in the chamber, now this is the difference between athletically endurance or athletically based adaptations to the heart versus disease based. When we athletically adjust the heart, what's happening is that contraction's becoming stronger and we're able to increase the amount of volume. All right. If we're looking at thickness of the wall, yeah, it gets thicker, which means that it's stronger and we're pumping more blood out. Disease ridden. Okay. So real quick, sorry, back one more here. Athletically, if our heart chamber, that ventricle is right here, okay, the cupping of my hand, what's happening is every time we contract, okay, we're pumping some out. Now, I'm always going to have a little bit left over, okay, and then it returns back. Now, if we're looking at it in a sense of disease state, meaning that our left ventricle gets thicker than that of athletic-based interventions here, what's happening is we're not getting that extra stretch that occurs with athletics. We're just getting the thickness of the wall, which inherently means that my cup or my chamber goes from here and over time gets so thick that it becomes smaller. All right. Now there's a point where this happens, and what's going to happen then is, now let's look at what would happen if I contract. I don't have enough room. First of all, I don't have the volume. Second of all, I'm not able to contract as strong, so that means I'm leaving a lot of blood left over in the chamber, which inherently means that there's less blood to the system, less oxygen. Okay, you see the cascade of events that can happen. So that's how we utilize ejection fraction in a clinical setting. Here we go. Heart rate. Your heart rate's not going to change in terms of its max. Now, it may be where you can start to push yourself closer to your max, okay? So that, I guess you could say, is technically a change. And even then, when we sit there and we tell you, if you're a 30-year-old, your max heart rate's 190, you're not going to die if you go to 195. And you can go a little past that theoretical max, okay? That's just telling us that you shouldn't be going much higher than 190, meaning inherently your max heart rate should be roughly 190. But what's going to happen is that we see that there is a decrease in your heart rate at submax exercise and at rest, meaning that you're doing the same amount of work with a lower heart rate. Where do you think that that comes into play? That increased stroke volume that we just talked about. Excuse me. We start to see a decrease in that sympathetic aspect, meaning that it's going to take a little bit more for us to reach that point at which the heart rate decides to start really climbing. And we see an increase in that parasympathetic, meaning we see an increase in that vagal tone. Heart rate recovery. So this is talking about the time to return to resting levels. When we look at pre-training versus post-training, we see it again. Why does it say elevated? Again, we're going back to that aspect of the parasympathetic and sympathetic activity. When we look at it for training reasons, like I said, look at the graph here. If we're exercising for 4 minutes, the heart rate for that of somebody who's trained is lower at a given time point or intensity, right, than somebody who's untrained. We reach the same amount. We're probably getting towards max, obviously, with 200. And then once we stop exercise, look at how we recover. We get back down to resting values a lot sooner. This is going to be more along the lines of our cardiorespiratory fitness. Again, this is where we start to see we have a greater impact from the parasympathetic. So it starts to take hold a lot sooner, therefore returning us back down to resting values. Cardiac output. Again, this is all kind of building on itself, and a lot of what I've already talked about kind of starts to answer some of this. When we look at it pre-training versus post-training, what has changed? Of this equation, what has changed that you think would allow for greater cardiac output post-training? Stroke volume, okay? And the simple fact that we're able to do more at a given workload, all right? It's simple as that. It's the same during submax and at rest. Again, the reason here why, and this is why you may get stuck for some reason, the reason it's the same at submax and at rest is because here's the deal. Untrained has a higher heart rate with lower stroke volume. Trained has a higher stroke volume with a lower heart rate. They still go hand in hand to make cardiac output. Okay? Now, the difference is when we trained, what did we increase? Did we increase our heart rate with training? No. What in that equation did we increase with training? It's our stroke volume. Well, if we increase our stroke volume, okay, yeah, I understand that it plateaus to a certain point, but what also starts to happen when we continue on? Well, that stroke volume plateaus at a certain point. We're not at our max heart rate yet. So now we're looking at heart rate taking over. Inherently, because that stroke volume increased, we see that increase in cardiac output. It's simple as that, guys. Blood flow. Another big adaptation when we're talking about training. It's increased to that active muscles. Again, because we have that AVO2 difference. Increased capillarization. Now, this isn't saying that we necessarily create new capillaries. The way I like to kind of put this example is we kind of have a branching system. Not to say that we can't kind of redistribute and kind of make a couple new pathways. We'll see that kind of occur when we have other things happen. But for the most part, let's think about it this way. Let's think about it in terms of a city and a lot of streets, right? Let's say you have the interstate, that's your artery, and then you hit into a city, that's your capillary bed, and then you hit the other side of the interstate after the city, that's your veins, right? You got to get through it. What happens when you start to see certain areas that aren't getting used? Or let's think about it in terms of maybe certain areas are under construction, okay? They close off the streets, which means that traffic cannot go there, right? Okay, think about it this way. Think about the less we're utilizing something, the blood's not wanting to go in there. I mean, it's not needing it. Even when we're sitting there saying, when we start to exercise, even at the beginning stages of exercise, of training and everything, as an untrained individual, the blood, yes, we're going to increase the amount of blood flow to the muscle, but even then, the body is not thinking that it's wanting to do a lot. So it's still going to go through some capillaries, but it's not going to infiltrate or go through all the capillaries. Well, now that we're increasing blood flow, because now we've increased our stroke volume and everything else, wow, okay, traffic is increasing. Well, if that's the case, and we are, needing to ease up the flow or at least allow for the traffic without getting congested, what do? All right, take down the barriers. Let's open up those streets. They're now done with construction. Well, guess what? That's how it kind of works. So now we're opening up and we're allowing blood flow to hit all the different avenues of our capillaries, which inherently is going to increase that blood flow to the active muscle. Okay. It's the greater recruitment. It's essentially saying, hey, we need you, so get ready. You're about to start being utilized, which is going to allow for more effective blood flow redistribution and increases total blood volume into that working musculature. More capillaries are formed to meet the demand of the trained muscles. Again, that's going to be a capillary to fiber ratio starts to come into play. More recruitment of the capillaries, so not all are open at one time. Now we're going to start to sit there and say, we need more of you to be open at once, okay? Increased cross-sectional area, more capillaries and increased recruiting, more area for exchange of that oxygen. So again, if you go sit there and you take a little tiny green fish net that they get your goldfish out at PetSmart, how many fish can you catch there? Not that many. Now go take, a big net and scoop through. You get more fish, right? Same kind of aspect. I mean, it's pretty crappy. I just use it because it's a net, and I always think of the capillaries as nets. But anyway, hopefully that doesn't confuse anybody. Blood pressure changes. There's little to no change in your resting blood pressure in a healthy person. Your systolic blood pressure is lower at a given intensity. I think we can kind of see that when we did some of the blood pressure labs. Not to make assumptions, but if we had individuals that were working and you heard the blood pressures correctly, if they seemed more fit or healthy, their blood pressure didn't really increase that fast. But some people, you may have seen that your blood pressure was increased pretty quickly, right? Okay. Hypertensive individuals can elicit a little bit of a decrease. And a lot of that's going to be because of the redistribution of blood flow. It's easing some of the tensions that are occurring, right? We're making some other cardiovascular adaptations that's kind of easing the pressure around places. But even then, it's not going to be as big of a difference. I mean, if you're sitting there and you're looking at some of the new blood pressure guidelines, if your resting systolic is at 155 or whatever, 150, even a 6 millimeters of mercury change is still going to have you at 143. Okay. Is that good that it's decreased? Yes. Obviously, that's not what I'm saying. But what I'm saying is you can't do it just purely off of exercise. There are going to need to be other interventions when we're talking about blood pressure. Plasma volume, increase in plasma proteins. So we got an increase in our oncotic pressure. Fluid follows. Aldosterone and ADH cause sodium and water retention, which means that we're going to increase the secretion from exercise, which means that we're going to sweat more. Or not necessarily sweat more, but we increase the amount of, well, sweating does increase, but we lose more salt from exercise as we do this, as we train. So hydration, it's always key, but it's really key when you're looking at trained individuals. Red blood cells, we'll start to see an increase in the number. Obviously, it's not going to be enough to be considered blood doping at a normal basis. I mean, if you live in altitude, it will be blood doping aspects, but hematocrit actually may decrease percent of the total volume due to more plasma being available. Viscosity decreases, meaning that there's better flow. And again, now the heart's not having to work as hard. So as you can see, a lot of this is becoming where we become more efficient cardiovascular wise, even at rest from aerobically based training. And when we look at hematocrit decreases, yes, we increased red blood cells, which means that we should inherently have an increase in hematocrit. But look what else we did. Unlike blood doping, right, where it would be seeing this increase in red blood cells, but no increase in plasma, so you increase your hematocrit. Now both are increasing. That plasma volume increases at a greater rate, so therefore that hematocrit actually goes down a little bit. Pulmonary ventilation. Training does not really change the structure or the basic function of your lungs. There's no change at rest. Decrease during submax, meaning that you are not having to breathe as hard or breathing as hard at submax exercises. It's going to actually be increased at max. Again, that's increased respiratory rate, and the respiratory muscles are contracting at that point. When we look at it, we have exercise-induced hypoxia. This is going to happen in highly trained athletes. It's a large amount of blood through the lungs, large right ventricle, less time for saturation. So we actually start to see an issue where, we're supposed to be having all these increases in oxygen carrying and everything else. Well, actually, we put too much blood through that it's not having enough time to load. Therefore, we're actually getting less oxygen in. But again, that's only in highly trained athletes. Pulmonary diffusion, there's no change at rest or at submax. It's increased at max due to lung perfusion, more blood to the lungs from the heart. Therefore, we get more air from our increased ventilation. Therefore, we have more oxygen coming into play. Again, not the same when you're looking at highly trained athletes that are pumping way too much blood through. AVO2 difference, saturation similar at the beginning of exercise and everything else, but it's increased to that the ability for offloading at all workloads. Again, when we start to see that there's more capillaries to pull the blood through. Therefore, we're increasing a lot of our myoglobin, which is going to take the blood from the oxygen from the blood and pull it into the muscle. And it's more of a significant aspect when we look at maximal exercise. So some of those muscle adaptations, capillary supply. Again, we talked about this, increase in the capillary to fiber ratio means that we have more area that's going to diffuse oxygen. Limiting factor in VO2 max. The biggest thing here is that we're going to, is the O2 to mitochondria kind of aspect. If you are somebody, if we're looking at fiber typing, most everybody's going to be right around 50-50. Type 1 to type 2. Depending upon the makeup of the musculature that you're utilizing and your own makeup, if you have more type 2 muscle fibers within that muscle or that musculature that's being worked, that's going to be a limiting factor because there's not enough mitochondria to utilize that oxygen. Increase in number of capillaries following training up to about 15%, meaning that we have about a 15% increase in utilization. Myoglobin, so like I just said, that's the little protein that takes the oxygen from the blood and pulls it into the muscle. We start to see that there's an increased number of myoglobin, which is going to help, again, pull it in and put it to that mitochondria. Training can increase this upwards of 75 to 80% in content. I mean, that's huge, especially when you start to think about all the other aspects that are going on. That if we're able to increase the amount of protein, essentially, that is pulling in the oxygen from the blood, then that increase in oxygen in the blood is not going to waste. And that was also going to start pulling in and helping create that larger AVO2 difference. Mitochondrial function, again, you're going to increase size, the number of mitochondria, so that oxidative capacity is going to be increased. Oxidative enzymes are increased for breaking down nutrients to be utilized and making ATP. That activity is increased, better used for glucose and fat metabolism, and you start to see that we're sparing our glycogen. So if we can spare glycogen, that means that we can move into utilizing fat as a fuel source a lot sooner. Lactate threshold, again, it's shifted. It's that oxidative capacity that's going to be doing that. We're able to shift into, again, if we're sparing our glycogen, we're shifting into utilizing fat for fuel at a faster rate, which means that we are pulling oxygen in, which means that we're not hitting that lactate threshold where it starts to overflow, right? So as we can see here, trained versus untrained, this lactate threshold may be right here for that red, and then it starts to increase. It's pushed all the way out to near 80% of your VO2. So let's just call this, who cares what your VO2 is, okay? Let's not even, because we're going to talk about why I'm saying let's not care what your VO2 is for a second here in a minute. But look what's happening. If I'm over here and I'm red and I'm untrained, I'm getting to that point of lactate threshold at only 55% of my VO2 max. If you and I have this, if red had the same VO2 max as blue, okay, because you can, even if you're not training, some people have higher VO2s just because of their body makeup, okay? Let's say red and blue have the same VO2 max. Who's going to be better? Blue is, because look, he's able to work, he or she is able to work at near 80% of that VO2 without getting being anaerobic in nature, right? So they're still aerobic at 80%. That's a big advantage, okay? We'll start talking about lactate threshold. This isn't more of a performance indicator, okay? Again, look at the same people. Look what starts to happen. I can speed up by near 3 miles per or kilometers per hour, or whatever that is in miles per hour. Again, you put that with the fact that I'm able to work at a higher percentage, or let's even put it this way. Let's not even look at where that lactate threshold is for a second, okay? Let's not say that we're going to work at near 80%. Let's work at, 70%. I can't do that, or red can't do that. 70% is putting them way up here, okay? So, okay, even without getting near my lactate threshold, blue is able to still compete at a higher performing aspect, okay? That RER, that respiratory exchange ratio, it's lower at all workloads. So what does that mean that we're using? I'll let you answer that, okay? Max oxygen consumption. It's increased again to all the different aspects that we just talked about. Your cardiac outputs increase, end-diastolic volumes increase, stroke volumes increase, ejection fraction increased, contractile force increased, capillary fiber ratio increased. Okay, 15 to 20% increases from previously sedentary individuals. That's pretty good. Okay, especially when you start talking about the fact that it takes a VO2 of I may change it all the time. It's like between 17 and 19 to vacuum your own house. Okay, to push and walk your house, pushing a vacuum, it's a 17 to 19 VO2, which if you had a VO2 that was measured as a VO2 max of 40, you're working at 50% of your workload already. Okay, with that being said, take that graph into consideration. Individual responses. So here again, just like we did with resistance training, there's individual responses. Training status. If you're lower trained, so you're untrained, for instance, you have a greater room for increase. Okay. If you're already highly trained, there's lower room for increase. Now, with that said, 2% for a highly trained individual could be the difference between not making a podium versus gold. So just because there's lower room for increase doesn't mean that that increase is still not able to be significant. Heredity. Genetics determines your finite VO2 range, meaning your mom and dad, the genetics that they gave you a range that your VO2 max can maximize itself at. Meaning that just because you go and you train and you do this or do that doesn't mean that we can train you and get you to a VO2 max of 80 or whatever it might be. Guess what? You could be the best in the world and your VO2 may only be a 65. Going back a couple slides, okay? Now that's where this would come into play. Let's just say that you have a VO2 of 65 and you're blue. And red over here has a VO2 max of 85. Lactate threshold is going to be more of an indicator of performance. Make sense? So even when you train, your genetics are going to kind of put your cap in a sense of where you can get to. And if you train, it's going to help determine if you can reach that range. Untrained females, their VO2 max is less than that of an untrained male. Again, this is because your VO2 max is also a little indicative of muscle mass. It plays a big part in it, and males carry more muscle mass than that of a female. So inherently, we're going to have a higher VO2 max no matter what at an untrained level. Untrained differences on average, 20 to 25% lower actually. Now, highly trained females are closer to the trained males. Like there's a 10% difference, if less than that. Okay. Don't pay attention to this. All right. Individual responses. There's a wide range of improvement from training. Again, why it's not to non-compliance. It's just because you have a different aspect. Are you a high responder or a low responder? Small or big changes. Some people, again, you could be somewhat near your VO2 max, or you may not have much further to go before that pinnacle of that your parents kind of set out for you. Other people may not be near it, and they may have a larger area to improve. Okay, it all just depends upon you and how you respond to the training that's going on. Now, please, when you look at this, do not get overwhelmed thinking that you're going to have to go in and put all this together. The reason that I have this on here is that it is a very good flow chart for how we increase VO2 max. If you didn't do anything to cardiac output, we got to change AVO2 difference, right? And what all goes into changing AVO2 difference? This graph is a good indicator, or at least a good summary of what we've talked about up to this point. So go in and just read through it. If you're having some issues following what some of the notes are saying, come to this chart and follow it, okay? Just turn the arrows the other way to see where, AVO2 difference, how do we do it? Increasing capillary number, so on and so forth, okay? Now, real quick, let's talk about anaerobic adaptations. So these are more muscle adaptations. So there's type 2A and type 2X undergo hypertrophy with this type of work. Type 1 hypertrophy, yes, they will increase in size, but they don't increase in size to the extent that type 2s will. Sprint training is not resistance training. I mean, technically it is, but this is what we're talking about, sprint training, not lifting of the weight, okay? May increase percentage of type 2A and reduce type 1 in the body. No, not necessarily. What it's going to do is it's going to make those type 1s more type 2 characteristically, and so on and so forth. Adaptations to the energy systems. The ATP PCR system, there's really no change. Increases due to increases in strength or force production. But glycolysis-wise, increases in glycolytic enzymes. So again, we're able to create energy at a faster pace in this sense. Increases in activity of important enzymes up to 10 to 25%. However, performance does not change. Indicating changes due to strength gains. Again, here we go. If we're looking at it, pre-training, post-training, we really don't see any differences, right? Maximal knee extension time. We start to see power increases, but we don't see anything. So again, we're not really changing performance-wise. A lot of this is going to be more indicative of the strength gains that we get. Okay, we'll see more changes there than we do anywhere else for performance. But glycolytically, we will start to see the enzymes increased. And cross-training, so more than one sport or activity at a time, so that's something similar to triathlon, or training several different components is what cross-training is. Now, if you are an athlete training for cardiorespiratory and strength, gains in strength, power, and endurance can occur, but power and strength are going to be blunted, meaning that they're not going to be reaching their potential. So if you're somebody who is an endurance athlete trying to gain power, strength, and everything else, and you're still maintaining all of your aerobic activity to the same extent, you're not going to get much stronger or much more powerful. Now, on the other hand, if you're an endurance athlete training with strength, you're not going to see any impact on your aerobic performance. So that will not decrease. What I'm saying is that aerobically will take precedent over anaerobic aspects. Okay? That's chapter 11, guys. So be on the lookout. We've got 2 chapters left, and then hopefully we will get everything rolling and ready for the final. See y'all later.